Okay.
Yeah.
Can everyone see that?
It is
Yeah.
okay, sir.
Okay. All right. Terrific. So I thank you for the very, very nice, introduction. I have really nothing to disclose, and I'll move straight to the case. So this is a 37-year-old woman who developed hypopituitarism following therapy for a craniopharyngioma at the age of 18 years. Her management then was then passed on to an adult endocrinologist for thyroid, adrenal, and sex hormone replacement therapies. She had a number of admissions for adrenal insufficiency, and over the last years, or at least since early adulthood, had been struggling to hold down a part-time job because of fatigue. She was sent to me, I suppose, as a third opinion for management of hypopituitarism, in particular, consideration of growth hormone replacement therapy. So when she came to me, these were her medications: thyroxine, 75 micrograms a day, hydrocortisone, purportedly around 30 milligrams a day. And she was a little bit evasive as to whether she took it once a day or split it twice a day, or if at all. And she had hypogonadism, following treatment for cranial, and was placed on sex steroid replacement therapy. So her main symptoms were chronic fatigue, general loss of vitality, difficulties with weight control, poor concentration, poor physical capacity, and she felt socially isolated due to fatigue. An examination, so she stands at 168 centimeters, weighed 81 kilograms, with a BMI of borderline obesity, 30 kilograms meter squared. She had normal breast development, but very, very scant body hairs. I thought her skin was pale and thin. She was plump with central adiposity. Much more concerning, she did not know what a steroid card was, nor did she wear a bracelet. And there she is. So these were the initial results of the investigations, and I'll take you through that. And I've shown in red all the results which are abnormal. So it is a very, very common finding when you evaluate someone with hypopituitarism to find quite a number of abnormal results in the face of seemingly replete replacement therapies. Anyway, to my horror, her IGF-1 was undetectable. LH and FSH were low. Estradiol was undetectable. Prolactin was normal. ACTH was low. A random cortisol, she was on hydrocortisone, at least taken on that day, showed that she was taking some hydrocortisone. TSH was undetectable, and a free T4 of 14. And we can go back to some of these results and discuss, the interpretation and whether it is in fact, or whether they are helpful in guiding management, because this case raises a lot of questions around a complex management problem. Anyway, to summarize, here we have a 38-year-old female on standard hormone replacement therapies for hypopituitarism since early adulthood, presenting with a persistent cluster of psychosocial symptoms, and for consideration of growth hormone replacement. So I use this case to highlight three things that I really want to cover, to give you an update on where we're at with adult growth hormone replacement therapies, a discussion about pituitary axis interactions in these patients, and focus more on optimizing sex steroid replacement in hypogonadal women. And it will become clear why this is. So just to remind you that about the physiology and the function of growth hormone in adults, after we stop growing, it plays a really important regulatory role concerning metabolic and structural functions of tissues and organs across all systems. So you can see whether it's heart, kidney, muscle, bone, liver, fat, brain, and skin. I won't read through all this. These are some of the actions of growth hormone on these various body systems. And in summary, growth hormone deficiency therefore causes multi-system health impairments that are difficult to quantify simplistically and which collectively reduces function and quality of life. And it's no wonder when you see it's got effects on the heart, muscle, and on general metabolism, and even on the brain. So the question when she came to me was, does she have growth hormone deficiency? And, based on Dr. Sujoy Ghosh's earlier lecture, I think he mentioned something about IGF-1. And in this instance, it was really undetectable. And is it really undetectable? That's the question. So in any case, when we assess such a patient, we should ask ourselves, who should be tested for growth hormone deficiency? Does this patient merit testing? Of course, because these are the recommendations of the US Endocrine Society and the Growth Hormone Research Society. People with a history of hypothalamic pituitary disease or after cranial radiation or pituitary tumor treatment, people with serious traumatic brain injury or subarachnoid hemorrhage, or someone with a childhood history of idiopathic growth hormone deficiency. And in particular in adults, if this is combined with pituitary axis deficits, the probability of growth hormone deficiency is extremely high. However, we should all be discouraged from testing for growth hormone deficiency in aging, obese people without any of this history for obvious reasons. So the typical clinical symptomatology is pretty non-specific, as you know, and truncal adiposity, reduced musculature, osteopenia, unfavorable metabolic profiles such as elevated lipids, the skin is thin and dry, reduced strength and fitness, impaired psychological well-being, and generally a subnormal quality of life. So what are some of the management issues around growth hormone replacement? What tests should be done? And if we do treat such patients, what dose? And because these patients are fairly overweight most of the time, is there a risk of diabetes because growth hormone is diabetogenic? And what are the pertinent hormone interactions with the other axis? And are there concerns about longer-term safety? So let me address one at a time. So how do we confirm the presence of growth hormone deficiency? Well, it needs to be confirmed by a validated growth hormone stimulation test. And the tests shown in red are those endorsed by the Growth Hormone Research Society, the Endocrine Society, and the European Endocrine Society. So briefly, the insulin tolerance test, glucagon, arginine plus GHRH. Now, although some of these other tests have been validated against normal controls for specificity and sensitivity, they are as yet not endorsed. And although growth hormone secretagogues such as GHRP6 and GHRP2 appear to be very, very promising, they are no longer under consideration because they're no longer produced. There has not been a market for that. And one of the problems with arginine, it is a very, very poor stimulator of growth hormone with a peak cutoff of 0.4 nanograms per mil. And of course, when you have such a low threshold for cutoff, you will therefore entertain a very high risk of false positives. So what are we left with in 2022? We're really left with insulin-induced hypoglycemia, use of glucagon, which is very familiar to all of you, and a new oral growth hormone secretagogue called mesamorelan. Now, this has been approved by the FDA and by the European medicines. It's not available in Australia, so I don't have any experience with it. But based on what's published, it's very, very discriminate in terms of its function. But I had to swallow hard and take a seat when I looked at its cost, that the cost of mesomorelin for diagnosis, one diagnostic test, is around $3,000 to $4,000. I kid you not, just go and Google it, okay? So in terms of everyday practice, we really have the ITT, the glucagon. There's always the question is a growth hormone stimulation test always necessary? Or we can turn the question around. When is the stimulation test unnecessary? Well, these are very, very nice data, which has been confirmed by many other centers, that when you have 3 or more pituitary hormone deficiencies and a low IGF-1, you remove the need for a growth hormone stimulation test. So when you look at a positive predictive value of 3 pituitary hormone deficiencies, excluding growth hormone, the PPV is 96%. When you have 4, it's 99%. And when you have a low IGF-1, so in this instance, is below the 3rd standard deviation. So when you combine low IGF-1 with 3 hormone deficiencies, your positive predictive value is already 100. Now, this is a practical approach. In Australia, growth hormone is subsidized by the taxpayer, and there are very, very rigid rules. So there is no exception. Everyone needs a growth hormone stimulation test. Although, as a caring physician, I have to bite my tongue to actually put this patient through a growth hormone stimulation test. Because if you don't provide the results, you don't get subsidy. But, that's politics. So, of course, the other area, people who do not need a growth hormone stimulation test when there are clear, proven genetic causes of deficiency, such as your PIT1 or your PROT1 deficiencies, GHRH receptor defects or mutations in the growth hormone gene itself. So that's the first step. Had this patient come to me after pituitary surgery, I would not rush to do a growth hormone stimulation test because it has been forgotten largely that you need to detect and correct pituitary hormone deficiencies before testing for growth hormone. Why? Here's the reason. In someone with central hypothyroidism, when you do a GHRH stimulation test, and if they remain hypothyroid, this is how much growth hormone is stimulated. But when you correct your central hypothyroidism, you get a normal response. So growth hormone physiology really depends on other systems being normal. And the same is true for cortisol. So here's a very, very nice paper showing the peak growth hormone response to either ITT or to arginine in an unreplaced hypopituitary patient with hypoadrenalism and after cortisol replacement. So you see in the unreplaced state, where the random cortisol is undetectable, you'll get no growth hormone response. But after a week of standard replacement, right, it restores the normal response. So this is something that we tend to forget as clinicians. After assessing someone after surgery, you immediately do a full blanket test of pituitary tests, and then you could misdiagnose growth hormone deficiency because of uncorrected hypothyroidism and hypoadrenalism. Well, what are the dose guiding principles for growth hormone replacement? Well, we know that in general, women secrete more growth hormone than men. Growth hormone secretion falls with aging. Growth hormone secretion is reducing obesity. It's maximally secreted at night for good metabolic reasons. And IGF-1 is a stable biomarker of growth hormone status. So based on these physiological properties, we kind of base our management guidelines on how much do women require compared to men? Do we give the same dose to the younger versus more elderly patients? Do we give more growth hormone to the obese because they're bigger and heavier? The answer is not. And when should we give growth hormone? Should we give it in the morning or at night? We try to mimic nature because, as you know, growth hormone is principally released at the onset of slow wave sleep. So these are the dosage guidelines from the professional societies that we should maximize benefit and minimize side effects. That weight-based regimens are strongly not recommended. So just because someone is 100 kilograms, that person should not receive more growth hormone than someone who is 60 kilograms, for the reason that growth hormone secretion is actually markedly reduced in obesity. In terms of starting dose, men in general require less growth hormone than women. So we would start at a dose of about 0.2 milligrams a day, women slightly higher, the elderly probably just 0.1 milligram a day, and gradually titrate upwards by 1 milligram every 1 to 2 months using IGF-1 as a guide. And growth hormone should be administered at night. So what are the glycemic risks? A lot of studies have been done, but I thought this is, kind of captures what the issue is or the size of the issue. So this is a meta-analysis from a French group from double-blind placebo-controlled trials, looking at growth hormone effects on a range of outcome measures, body composition, lipids, insulin levels, and glucose. So you can see that based on this meta-analysis, yes, growth hormone does put up fasting glucose slightly, but the effect size is very, very small. It only equates on an average of 0.22 millimoles per liter. Very, very small. But of course, one needs to be more cautious in the more obese patients when you start people on therapy. But because we're starting on a low dose, then the risk of inducing hypoglycemia or diabetes is very low. What about hormone axis interactions? Well, I like to talk about thyroid, effects on the thyroid system, adrenal system, and interactions with the pituitary gonadal system. While I will, because of time, I will not talk more about effects on thyroid. I think most of you know that growth hormone enhances peripheral conversion of T4 to T3, so that it is expected that free T4, if inadequately replaced, will fall during growth hormone therapy. And as Dr. Gosh says, you cannot use TSH as a something to titrate your thyroxine dose as you would in other forms of hypothyroidism, because these people have central hypothyroidism. So as the free T4 falls, the message is that you increase the free T4 dose to maintain it in the mid-normal range. Unfortunately, there's no other reliable marker for thyroxine or T3 adequacy other than using the population-based normal range. Now I want to talk about glucocorticoids, given that this patient has several episodes of near hypoadrenal crisis. Now, it's probably not all that well known that growth hormone inhibits the conversion of inactive cortisol to active cortisol. And therefore, with the commencement of growth hormone therapy, one could risk precipitating hypoadrenalism. I'll show you what I mean. So as most of you know, that there is a shuttle between cortisone, which is inactive, and cortisol. And the enzyme 11-beta-HSD activates inactive cortisol to convert it to cortisol. Then there is its sister enzyme, which does the opposite. It activates cortisol to cortisone. And for all of you, I'm sure you all know that prednisone is inactive and prednisolone is the active counterpart. Thing is, it's known that growth hormone inhibits 11-beta-HSD activity. So that as we start growth hormone, if this enzyme is inhibited, then there will be less conversion of cortisone to cortisol. That's shown here. So this is again a nice study, and looking at the cortisol response to ITT in 12 patients with growth hormone deficiency and preserve function of the pituitary adrenal axis. Before growth hormone therapy, this was the cortisol response to ITT. After commencement of growth hormone for about a month, the repeated growth hormone response was substantially lower. And these people unmasked central hypothyroidism. I think it was in 8 or 9 of the 12 people. So they concluded that growth hormone therapy may unmask central hypothyroidism or increase susceptibility to adrenal crisis in these patients who are steroid dependent. Now, how true is it? Well, I can tell you, it's not grandmother's story. Here was a large Australian multi-center trial of growth hormone treatment in deficient subjects many years ago now. So there were 166 patients randomized to either growth hormone or placebo for 6 months. And during that period, 5 patients developed adrenal insufficiency. This is double-blind, placebo-controlled. All 5 were in the growth hormone group. And there were 2 episodes in collapse in growth hormone treated patients. Now, is this an Australian experience? No. Some years later, these are publications from the Kim's group. It's entitled Deaths Among Adult Patients with Hypopituitarism, Hypocortisolism During Acute Stress and De Novo Malignant Brain Tumors Contribute to an Increased Mortality. So these investigators looked at mortality in over 1,000 hypopituitary patients from the Kim's database over 10 years. And when you look at the standardized mortality ratio for the entire group, it was increased, okay, 1.42, and that's the confidence limits. But when you broke it up and looked at the subgroups of people who were ACTH sufficient and ACTH deficient, you can see that the ACTH sufficient group really did not have increased risk of mortality as compared with the ACTH deficient group. And these investigators reported 13 deaths from infections, and all of these people were ACTH deficient. So this is a really important clinical point of management. Then I want to move on to sex steroids. So these are data from Swedish group, and they've followed longitudinally the experience over 5 or 6 years. And in over 100 patients, they looked at the dose of growth hormone in milligrams per day over the 5 years. And they found, like most of these trials, at the start of therapy, I think most of the patients were probably overtreated based on the IGF-1 titration. And then over the years, there was a gradual reduction in growth hormone dose to keep the IGF in the normal range. And I should have said men are shown in squares and women shown in diamonds. But if you looked at the dose expressed as micrograms per kilogram per day, you can see that women in general required higher doses than men, even though in both sexes, the required dose reduced with time. But when you look at the corresponding IGF levels, you can see that although the women were having higher growth hormone doses, the IGF-1 levels were climbing up within the normal range. Whereas in men, although the doses were reduced by more, they were substantially overtreated over the last 5 years. So clearly, this shows that under close management, some patients still tend to be overtreated and some undertreated. And this phenomenon is gender dependent. So why is this? Well, I want to talk about sex steroid replacement for hypogonadal women, specifically addressing the root of estrogen therapy and the types of estrogens that we should be using. So I think all of you know that the liver, shown here, is a principal target organ of growth hormone action. And growth hormone induces the liver to do lots of things, but principally to make IGF-1, which in turn will increase your lean body mass. It also stimulates hepatic lipid utilization and oxidation, which then leads on to a reduction in total fat mass. The thing with estrogens is the first pass hepatic effect. That most forms of estrogens, at least in Western society, is taken orally as the pill. And the first pass hepatic effect of estrogen inhibits growth hormone action such that it then impairs lipid oxidation and it impairs the generation of IGF-1 and therefore impairs some of these beneficial effects that we are trying to treat. So this is a study that we did many years ago in one group of postmenopausal women in a two-phase study. In one phase, they were either randomized to a period of oral estrogen before swapping over to another period of transdermal estrogen, but the order of the sequence was also randomized. But be that as it may, this tells a story. So before growth hormone and estrogen therapy, this was the mean IGF-1 level, about 12. Then when the women were randomized to the oral route, the IGF-1 levels fell. But whereas when they were randomized to a transdermal route without growth hormone, the IGF-1 levels did not change. Then they were then put on to stepwise escalating doses of growth hormone. So you can see that those during the oral estrogen treatment phase did show a small stepwise increase in IGF-1 as the dose of growth hormone replacement was stepped up. But when the same women were placed on estrogens via the transdermal route, you can see that there was a greater increase in the IGF-1 response, such that for 2 milliunits per day of growth hormone during the oral estrogen phase, this equated to half the 50% growth hormone dose in the same women taken transdermal estrogen. So there was a 50% reduction in growth hormone efficacy. And this summarizes a lot of data looking at growth hormone resistance as a function of transdermal estrogen and the type of estrogens given orally. So I'll just take you through this. If the patients were not taking estrogens, this was the IGF sensitivity or IGF response. If placed on transdermal estrogens, these two were not significantly different. But when placed on conjugated oral estrogens, such as Premarin, you can see that there's a 40% reduction. And the reduction was probably similar, or in fact a little bit greater, if placed on 17-beta estradiol. But if placed on oral contraceptive steroids, such as ethinyl estradiol, at a dose of 30 micrograms a day, you can see that the efficacy of growth hormone is now about just 30% of what it should have been. So when you look at costs, oral therapy adds an additional growth hormone cost of between 5 to 10,000, this is Australian dollars, per patient per annum. So let's look at medical practice, okay? So there's a nice study from Leeds published years ago. I don't know, sorry about that, don't worry about that. But they looked at estrogen replacement therapy amongst their centers group of hypopituitary women and found that about 30% for estrogen replacement therapy were placed on oral contraceptive steroids. 56% were taking estrogens in the form of either conjugated or 17-beta estradiol. And less than 50%, or I mean less than 20% were taking estrogens transdermally. So this is glaring suboptimal practice. So this study was published in 2005. Then there was another study that appeared from South America some 7 years later, and they look at their spread of estrogen therapy. And you can see that publications about all these things really, it has no impact, because most of these women were still placed on oral contraceptives, which is wrong. And the majority are not on oral contraceptives, taking oral estrogens, and only a very small proportion on transdermal estrogens. So there were absent trends in proper prescribing of estrogens for hypopituitary women. So I just want to come back to some general principles about management. That in my patient, using her as an example, she was persuaded to take hydrocortisone twice daily, split dose, and she got a steroid card and a bracelet, and was given sick day management repeatedly, and touch wood, no further adrenal crisis. In terms of a sex steroid management, pill was stopped, commenced on transdermal estrogen patch, 100 micrograms a day, cycled with medroxyprogesterone acetate, 5 milligrams a day for the first 12 days. And the IGF-1 rose before growth hormone from undetectable to about 4 nanomoles per liter. Then she was commenced on growth hormone at that dose, steadily increasing to maintain the IGF-1 in a normal range. So let me share her personal data with you. So this slide shows the IGF-1 levels shown in pink in nanomoles per liter at baseline, 6 weeks, 16, and 24 weeks of growth hormone therapy. And the growth hormone dose is shown in green, starting initially at 0.1 and then gradually up to 0.2 and then 0.5 milligrams a day. So you can see that her IGF-1 levels went up from undetectable to 4 without growth hormone treatment, and then she then displayed a dose-dependent increase in IGF-1 levels. At the time that we were also doing some intensive patient-reported studies looking at quality of life, and a group of our patients were put on pedometer, looking at step counts. So you can see, if we look at step counts, that before therapy, this patient was barely doing 1,000 steps a day. And that with therapy, she gradually went up to about 10,000 steps a day. Now, those of you who are familiar with quality of life questionnaires, based on a score of 25, if your life was perfect and you did not have a suppressed quality of life, your score should be 0. So a score of 20 or 25 is really a hermit existence. But at least over half a year, see that her quality of life did improve. And then with time, this is what she reported. improved quality of life, and was able to get full-time employment. So, to summarize, what are the strategies for optimizing the accuracy, efficacy, and safety of growth hormone therapy and treatment of hypopituitarism? Who to test? Those with a high likelihood of growth hormone deficiency. We should detect and correct hormone deficiencies before testing for growth hormone using only validated diagnostic tests. The doses should be individualized. We should be aware of hormone axis interactions. If hypogonadal, avoid the oral route of estrogen replacement. These people have a high cardiovascular risk, and we should optimize the management of cardiovascular risk. If they're obese, we do the usual things that we might do for our patients with diabetes and implement low lipid lowering agents. We should continue to manage the primary causes of growth hormone deficiency, such as a residual tumor or craniopharyngioma. And it's really important to participate in registries and observational studies because we're still learning about these things. So in the initial 6 months of therapy, before maintenance, the dose should be individualized by titrating against IGF-1. Watch your interactions with regards to thyroid hormone concentrations, glucocorticoid requirements, and I've mentioned sex steroid requirements. You should monitor your body biochemistries, your cardiovascular risk markers, body weight, body composition, waist circumference. It's quite sensitive for growth hormone deficiency because central adiposity is a primary manifestation. Quality of life does not necessarily require a questionnaire. You just ask the patient. And this sort of therapy, I suppose, is like type 1 diabetes, you know. If they do not feel that the injections, the inconvenience of injections are overcome by the benefits, they will not continue with it. And then there are generic issues to look at, residual tumor monitoring, and then beware of malignancy prophylaxis and screening. So I want to stop there and thank you for inviting me and happy to take questions.
Thank you, Dr. Ho. I think we have not much time, but you can have this video of the Synox now. Yes, we have one or two questions in our chat box, but I would love to ask one question to you from the delegates. That when you were giving the growth hormone therapy for the adults, say for example after the pituitary surgery, you are giving growth hormone replacement therapy. So I think you would like to give it for the rest of the life. This is the first question. And if you're giving it for the rest of the life, do you want to taper it down a little bit in the elderly subjects? Say you are started at the age of 25 after the pituitary surgery, what will be the strategy for the elderly subjects?
So you're talking about growth hormone replacement therapy, right, and men?
Yeah, and men.
Yeah. Okay. So look, so when we look at the general principles around hormone replacement therapy, if you ask me the same question about thyroid deficiency and glucocorticoid deficiency, you'll know what my answer is, right? It will be for life. Mm-hmm. Yeah. Now, of course, growth hormone is a younger cousin here, but and people are also trying to get an experience about cost benefit. So a lot depends on the health system. Mm-hmm. In Australia, we are very fortunate with government subsidy of growth, an expensive drug, you know, with very, very strict criteria. Mm-hmm. Whereas I suppose, you know, in some countries where there's no government subsidy or insurance subsidy, then it's user pay. So it becomes very, very difficult. And these expense then clouds what is essentially should be an endocrine benefit. Now, what I can say is that if I were a patient and you told me you must take this injection every day, all right, and your insurance company is not going to charge you, I don't think I will be giving myself the daily injection if I did not feel a benefit. And there's a really very important study from New Zealand, actually, where the government subsidy criteria is even stricter. And they followed something like 200 patients over 3 years and only had a dropout rate of about 5 to 7% of patients. So I think that's incredible.
So there is another question that again about the doubt of giving the growth hormone replacement therapy in the adult again. So apart from the improvement in the quality of life, is there any other hard data to support growth hormone replacement in adult with pan-hypopituitarism? Apart from the improvement in the quality of life, any hard data, say cardiovascular outcome data, do we have any outcome data about prevention of the mortality?
The short answer is yes, Dr. Mazumba, but because of time, I really didn't want to show you all the data. But one of the most consistent findings is the improvement in body composition, reduction in central abdominal fat, increase in lean body mass, and then there's increasing strong evidence about improvement in lipid profiles, etc. Whether it does anything for longevity is unclear, but growth hormone replacement was never sold as something to prolong life. It's only in the anti-aging world that's what it does, is being sold.
Do we have hard data that it can prevent mortality or increase the longevity? Any hard data that it actually increases the longevity or it prevents the all-cause mortality?
Yeah. So the question you should be asking first is how strong are the data that growth hormone deficiency causes premature mortality? All right. and it's controversial, and the data are a little bit soft. But it's very hard to judge because these people, have mixed complex disease. So you can't, it's very hard to pick out, was it growth hormone deficiency? Was it too much hydrocortisone? Or was it because we never gave them testosterone? This sort of stuff. So it's an open question. Yeah.
Okay.
Thank you, sir. It's the general principles of hormone replacement therapy.
Okay. Thank you, sir. We have learned a lot, and I convey our sincere thanks for this wonderful lecture. And now I hand over this podium or the screen to Dr. Shomu Brutharajadi. Over to Shomu, please.